Okay. Hi guys. I'll press play. Hi guys, welcome to Certificate 4 in Mental Health. Tonight's topic is CHC MS007, Working Effectively in Trauma-Informed Care. Before I start, what do you guys think trauma-informed care means? Did anyone watch the video? Like, what do you think that means?
I watched it, but I still don't understand it that well. So I'll be all a bit new to trauma-informed care.
Yeah,
I think it's yeah, watch the video. Yeah, it's really good. Very animated video and understanding that trauma-informed care is more like we pay attention to the background of the client, and
mm,
then we are more careful in it, our design plan and interactions not to re-traumatize the client. Yeah, and
yeah,
like with our process and things like that.
yeah. So my number one, so um, just so you guys know, because I taught the other unit, but most of my experience has been in mental health. I've worked in mental health for 10 years. Since January this year, I started working in domestic violence, and trauma-informed care is huge in this industry, but it also relates to mental health as well, and all different types of community services. And you'll find this a lot in Certificate for Mental Health, that we don't want to re-traumatize people who've had really horrible experiences. The one thing I want to say about trauma too is that different people experience things differently. So Joe Blogg could have a car accident and be fine, but his brother could experience trauma from that accident. So it's really individual um of how we experience trauma. So I
And
want to
also, sorry, yeah.
no, Tanya, sorry, you go.
No, I was just going to say sometimes trauma manifests in really different ways for people too. Like for some people, it can be, hypervigilance, or some people it can be kind of being really withdrawn, or, you know, eating disorders and things like that. So it's not just a one size, everyone's traumatized will act and behave the same
Yeah,
way.
yeah,
So
yeah,
that kind of
yeah,
personalization of treatments as well. Yeah.
yeah,
Sorry, I
definitely.
didn't
So
mean
we
to
have the
interrupt you.
person. No, that was great. So we have the personalization of experience from the trauma, but we also have the impact of that experience being personalized as well. Is that what you were saying, Tanya?
Yeah, pretty much that, it manifests in different ways for people. So for some
Yeah,
people, their trauma might make them really withdrawn. In other people, they kind of might, they might be really outgoing, or they may have kind of what looks like ADHD symptoms, or
Yeah, so they can go into the hyper status and or they can go to the hypo status. They can be freeze or they can be like acting out
yeah.
aggressive.
yeah,
And
It's
different
different
things will
ways.
trigger people. Like some people hate loud noises, some people hate dark spaces, like it,
mm,
it depends on the person and their experiences and
mm,
what kind of shapes their trauma, I guess. Yeah.
yeah. So I would say that you're all studying certificate for mental health. I would say that you all have a desire to help people, and part of that is it can be really unhelpful for people to I call it ruminate, where they go around in a circle and they start talking about the same thing over and over and over again. That can be actually unhelpful to listen to repetitively because it makes them feel worse. The With trauma informed care, we want to make sure that they feel as comfortable and safe as possible. Um, I've forgotten to do the acknowledgement of country, so I'll just quickly do that before we start talking more about trauma. I want to pay my respects to the past, present, and emerging Gurja people on the land on which I live. It was and always will be their land. So yeah, look, you already know a little bit about me. My name's Jackie. I'm your trainer. I'm a registered social worker with the Australian Association of Social Workers. I spent most of my career in mental health, however, currently working in domestic violence. If any of the content is triggering, we have Lifeline on 13, 11, 14, and we have our Southwest TAFE Wellbeing Service, Deb Brevis, who covers Warrnambool, Colac, Glen Orson, and Sherwood Park campuses. Today's lesson objectives is one, define trauma and trauma-informed care. Two, recognize the impact of trauma on the individual's, hang on, I'm just gonna move this, health and behavior. Identify the key principles of trauma-informed care. So, who had a chance to watch the video? Lisa, did you watch, Tanya, anyone watch the video on trauma-informed practice?
Yeah, I did, but I don't remember this one too well. But anyway, yes, I did. Watched them all today.
Yeah, that's okay. What did you think of the video?
I don't remember which one it was. Sorry, I'm probably not very
Oh,
helpful.
that's okay.
The very
That's okay.
animated one. Yeah.
Yeah, yeah. What did you think, Ying?
I think it's actually very, as I said, very easy to understand what is trauma informed, like
Yeah,
the concept of it. Yeah.
yeah,
So it's
yeah,
very simple. Yeah.
yeah. Cool. Okay, we'll just go to if you guys, I've sent you the email with the link, so if you want to watch them later, that's okay. So what does trauma mean for you? We talked a little bit about different experiences. Trauma is a deeply distressing or disturbing experience. Trauma-informed care is a service that delivers approach that recognizes the widespread impact on trauma and emphasizes physical and psychological safety for both service providers and individuals receiving care. Okay, so the trauma-informed principles. We have safety. So you will have noticed at the start of my presentation, I talked a little bit about safety. That's the same for your clients as well. They need to know that you're a safe person, that you're not going to that you're not going to trigger them, that you're going to be there, that this is an open space for them to talk about, and that links into the next one, the trustworthy and transparency. A lot of the time, when you work in community services or mental health, who your clients are and what your clients tell you is confidential, and they trust you. Like, they trust that you can't say that because they deserve the right to have privacy and confidentiality, and that's important too. In in mental health, there's been a big movement. I'm not sure if you're aware, around peer support. Peer support is someone with a lived experience working in the space. So over the last 10 years, I've really seen South West Healthcare, the hospital in Warrnambool, employ more peer workers, and the movement for peer workers come up as well. Peer work can be in mental health, but it can also be domestic violence too. And we see sometimes people with lived experience of domestic violence, they get into the industry and they understand what it's like to have these experiences. Um, the next trauma-informed principle is collaboration and mutuality, which means that we're walking beside our clients. We're not giving them sympathy. We're giving empathy. We work in conjunction with them. We always check into, oh, do you feel comfortable talking about this? Or, would it be okay if we talked about this? Or, oh, that sounds really hard. Not, there's a difference between sympathy and empathy. Empowerment, voice, and choice. We want to give people, unfortunately, in mental health and in domestic violence, a lot of our clients will have had their voice taken away from them. People will act on their behalf, and we need to remember that and give them empowerment to speak and give them choice about what they do. We also need to be culturally aware of different cultures, different ethnicities, and how this can impact people, and gender issues as well. We know too that people that are LGBTQI will experience higher rates of mental illness and higher rates of domestic violence as well. And we just need to be sensitive to these topics. Okay, so I've got the next slide is just some practical strategies around working with people in trauma-informed care. Using non-judgmental language. So not saying, unfortunately, there's a lot of stereotypes around mental health. People will call someone a schizo or a psycho, or they'll call someone, they'll define someone by their illness rather than the person. For example, that's a schizophrenic man rather than that has a man with schizophrenia. There's differences in the language that we use. We need to also respect people's personal pronouns. So sometimes people will they'll prefer she or he or they. We need to respect that, and in our notes we need to write gender neutral language unless we've been told otherwise to respect our clients. We want to avoid re-traumatizing people. So we want to let people tell them as much as we can about we want to let people tell us much as they can about what's comfortable for them. The other one is the supporting the emotional regulation. Does anyone have any know much about this? Ning or
No.
Sorry, which one? Sorry.
supporting emotional regulation. So when we're feeling really
Yes.
overwhelmed, does anyone
Sorry.
have any tip? No, that's okay. When someone's feeling overwhelmed, does anyone have any things that help them feel less overwhelmed? I think that's the right question.
We practice in our playroom. So
Mhm.
when we are working on like a play therapist theory, one of the things is
Mm,
like we're working as a co-regulator.
mm,
So like even in the classroom, teachers and anyone can be a co-regulator. So we will be co-regulating with the children or the clients, deep
mm.
breathing,
Yep.
doing some meditation movement, distracting, or like identifying the emotions as well if it's appropriate at that time. Yeah. So or there's a lot of emotional
Mm.
regulations method
Yeah.
depends on different
Yeah.
people. Yeah.
This is like a
I do a lot
huge
of it with
topic.
my sorry.
No, you do a lot with your son.
With my son, my son's got ADHD, so we do a lot of emotional regulation stuff. A lot of it's around the breathing, because he tends to get quite overwhelmed. So we do like square breathing and balloon breathing, a lot
Mm,
of tapping and EFT tapping he loves.
mm,
Um, a lot of it, and I find a lot of stuff around like the nervous system regulation, like knowing, what your vagus nerve is and how it works and how to release your vagus nerve. Um, but even that kind of, naming the feeling, but also we do a lot of stuff about, is this an elephant, is it a mouse problem or an elephant problem? And he'll often say, I'm feeling really worried. I'm like, how big's the problem? Is it like aliens landing on the roof kind of fear, or is it, there's an ant on my food kind of fear? So it's kind of,
yeah.
putting things into perspective and how, just kind of naming it kind of helps to shrink the problem down and go, oh, actually, it's only a tiny little problem. This is how I can work through it.
Yeah, yeah.
So,
And I noticed too that you talked about the deep breathing. Deep breathing's another tool that's really great to use with our clients because number one, as evidence-based, it actually works for a lot of people. And number two, it's free and available for clients. So we said in the last session too that we don't want to have expensive tools. We want our tools to be cheap or free for our clients to use. Otherwise, they're less likely to use those strategies at home if they can't afford it. So the deep
yeah.
breathing. And one of the ones so there's a whole people have done a whole masters on this on emotional regulation. There's so much research out there. But one of the ones that I often talk to clients about is butterfly tapping, which I can show you on the camera because it's free and it slows down the nervous system as well. So you cross it. I think maybe could we all have a go at doing it? Just would that be okay? Yeah. So we're going to cross our arms and we're going to tap. And you can tap slower or faster. And what this does is it helps slow down your heart rate as well, and it slows your body down because you want to go with the rhythm. Tanya, is that one you
Um,
use with it?
Yeah, I've used that with my son, but also one thing that someone said to me when my babies were really little was that the babies will copy your breathing. And as
Mm,
a new mother, you kind of tend to, especially when they're crying, and you tend to breathe really fast. So if you
mm,
consciously slow down your breathing, then the baby
mm,
copies that as well. So, and I think it's kind of that stress response automatically going, my baby's crying and they won't shut up, and
mm.
you tend
Yeah,
to breathe faster when you consciously slow it down. Um, that can help to regulate their stress response as well.
yeah, yeah. And one of the other ones that I use a lot in therapy as well is 5, 4, 3, 2, 1. Has anyone heard of that before? No. So 5 things that you can see. So have a look and see
oh,
if you can
yeah.
see.
Yeah,
Yeah,
Is
we
the
you've done it
senses
before.
one?
practice that a
Yeah.
lot.
Yeah.
Yeah.
Yeah. My son got taught this with his anxiety. They're like, yeah, think of things what you can taste at the moment. What can you see? or can you hear just to keep repeating that? But I don't know if that's the same thing, but
Yeah, no, that is the same thing, and it's extremely common. We use it a lot in practice as well because it's a distraction technique too. So if we're over worried about our trauma or we're thinking a lot about what's happening, it gets us to stop that and breaks the cycle, thinking too much.
And the
And
good
I
thing about
think
these things is that it's not that like having an obvious fidget toy or something, that you're holding and doing can make people kind of look at you while you're doing it. Whereas,
Yeah,
doing the breathing and doing the five senses thing, you can just do it in your head. You can just sit there and kind of zone out for a minute and go, I'm just going to focus on my breathing. And no one
yeah,
knows what you're doing or what you're thinking
yeah,
about, but you kind of, you're internally calming yourself down.
yeah. So in mental health in the facility I work at, it's called the Prevention and Recovery Centre. We have a whole room separated for sense. We call it the sensory room, and it's got like lots of toys that people can play with and fiddle with and work out what they like. And then it's got sense like you can smell. It's got oils that you can use, such you can smell. It's got a massage chair. Usually we try to promote like free and stuff, but the massage chair is really good. The other one that people find really helpful is a weighted blanket. That can be really helpful as well. Yeah, so we're going to do a bit of a case study around Jake. Jake is not a real person. Jake is someone that I got from AI. Um, so he's not a real person, but it does tell you a little bit about his story and his mental health journey. Um, yeah, okay. Would you like me guys to read it, or do you want to read it to yourself, or what would work for you guys?
might read it together. If you want to read it,
Yeah.
then we can go through.
Yeah. Yep. Okay. Hang on, I'll just move the I'll just move the people. Okay. Well, so Jake, hang on. Maybe if I move, maybe I'll put it up top. Yeah. Okay. So Jake is a 27-year-old man who has recently been referred to a community mental health services by his GP. He presents with symptoms of anxiety, hypervigilance, emotional numbness, difficulty sleeping, and socially withdrawn. Jake is unemployed and is currently living in a crisis accommodation service. During the intake session, Jake appears guarded, avoids eye contact, and speaks minimally. Over time, he discusses that he experienced childhood trauma, including physical and emotional abuse from a caregiver. He also reveals he was exposed to domestic violence and was placed in foster care at age 11. In his teens, Jake was briefly homeless and had episodes of substance abuse. Jake has never engaged in long-term mental health support and expresses distrust in the system. He's wary of authority figures and reluctant to participate in group therapy. He has a history of panic attacks and was once involuntarily admitted after a suicide attempt 3 years ago. What do you guys? Okay, so question 1. What are the key signs that Jake may have experienced trauma? What do you guys think? Ying, what do you think?
So all his behaviors of like sleeping issues, key signs that Jake may have. So his history actually has told us that he has experienced different types of trauma at different ages.
Yeah.
And it's reflecting it that is severely impacting his mental health and his daily life as well. Yeah.
Yeah. So you're saying it's impacted, you can tell that it's impacting his daily life and is impacted by the trauma. Yeah. So in the
Yeah.
case study, yeah. So in the case study too, it said, why might Jake be hesitant to trust mental health services? What do you guys reckon?
Been in foster care before, he doesn't trust the system, and
Mm,
also people trying to help him have just led him into more trauma. So
So
yeah.
it's been like re-traumatized.
yeah.
Yeah. Yeah. Yeah. And I think too, he hasn't had a good experience like you were saying with the foster care, he hasn't had a good experience with people, with professionals, and sometimes people can be a little bit cautious of services as well. Yeah. Okay. How does a trauma-informed approach differ from a traditional mental health response? A good question.
I think giving him enough time to open up, like he's obviously very reluctant to talk. He's very, even like from what you said, from the way he's sitting and the way he's avoiding eye contact and that, like not trying to force him to do something that he's not ready for or not comfortable with.
Yeah.
And he said like he doesn't want to do group work or something like that. Like really listening to what he's saying and verbally and non-verbally about
Mm.
his level of trust and his readiness to engage with different therapies, I guess.
I
Yeah.
think, yeah.
And yeah.
I
So
think
you
traditional
think?
mental health response is very solution focused and task focused, whereas like the specific timelines we have to fix this problem, that problem.
Yeah.
Whereas like trauma informed approach is very carefully looking into the process of building up the trust and relational safety so that the client is not being re-traumatized and take their time to reprocess the experience and make sense of those. Yeah.
Yeah. Yeah. Oops. Sorry. Yeah. Okay. Um, that's yeah. Okay. Um, so also too in the case study, it talked a little bit about Jake having an involuntary service, and unfortunately, in the Mental Health Acts are state-based, and in Victoria we have a system where we have compulsory mental health treatment. So people that are at risk of harm to themselves or their others will sometimes be placed in hospital, even though they don't want that. And they say they don't want that. That's yeah, unfortunately, that sometimes happens. So, but that can be the same as the mental health response as well as the trust response. Um, yeah, and the next question: what might be some of the risk of re-traumatizing Jake's care, and how can these be avoided? What do you guys think?
I think it might be worth investigating with him. Like, is there a particular profile of person that he trusts more? Like him, he may have been traumatized by men and therefore, avoiding male nurses or male carers might be a way
Mm,
to kind of, help him with that, or he might work better with older women or younger women, or just being kind of sensitive to, I guess, if there's a particular
mm.
profile of someone who's caused that trauma,
Yeah,
might be one
that's
way
a
to
good point.
kind of just I guess it's not always possible and it's not always manageable, but just I
Mm,
guess being sensitive to that, does he like people with softer voice? Some people have really loud voices and they're really
mm,
over, over enthusiastic and that might be triggering for him. So just I guess being aware of that stuff.
Yeah.
yeah, yeah, yeah. Okay. Yeah, just being aware of that he's had it really tough and he's had a bit of trauma. So some of the people in this course in our Cert 4 program will have a lived experience, and that's one of the reasons they're doing the Cert 4 is to work in that industry. What do you think someone who has a lived experience of mental health could help um could help with trauma informed care? How do you think they could help?
I think they can provide that kind of not necessarily aspirational that everyone who gets better is going to become a care worker, but kind of that recovery is possible and you can you know things will get better and things will move through and there is kind of the light at the end of the tunnel kind of thing, but also they
Mm,
have that kind of understanding of I know how much bloody hard work you're going to have to do to get to the other side. Whereas I
mm,
think if the carer hasn't had that kind of experience, they might just be a bit dismissive of it and go, "Oh, just wake up and go for a run every day," kind of, and
yeah,
that. Whereas when you've been there and done that, you kind of go, "I know it's going to be super hard, but it will be worth it."
yeah. You understand how tough it is. Is that what you're saying, Tanya?
Yeah, yeah.
Yeah, that's a really good point. Yeah, yeah. And people with lived experience will have their own triggers around trauma as well, and they can relate to that as well. Um, yeah, does anyone want to add anything to that?
I think I very strongly believe in interpersonal neurobiology, and we believe that by creating a relational safety, like just being with. You don't need a lot
Mm.
of questions, skills, and strategies and things like that. The thing is that you're just being with them and non-judgmentally creating the space, and will let the brain rewire the whole nerve system, and then we can
Yeah.
actually process it, and recovery is possible. Yeah.
Yeah. Okay. And our last question is, how would you support Jake to feel empowered in his recovery journey? What do you think, Tanya?
Um, I think having kind of clear goals, clear and achievable goals. Like I think he's probably having such a long history, like since he was like 11 years old at least.
Yeah.
You know, you're talking 17, nearly 20 years probably, if you include all his childhood. You know, he's
Yeah.
probably tried and failed so many times, or felt like
Mm.
he's tried and failed so many times. So kind of putting those failures, I guess, not that they're failures, but those attempts into perspective, and getting
Yeah.
them that, kind of, this
Yeah.
time can be different. So maybe that sense of hope that,
Mm.
it
Yeah.
it's not a life sentence just because you've had these things happen to you, but there is something better there.
Yeah. So often at the Prevention and Recovery Centre, which is the centre that I work casually at, we use SMART goals, which is specific, measurable, achievable, and realistic and timely. We will do there will be a lot of the SMART goal content in the recovery orientated unit. In mental health, we'll cover the goals as well. You want to set people up for success. If you set them up with goals that they're not going to achieve, they're just going to feel crap. So the SMART goals are the sort of the thing that we work with people around. And at the Prevention and Recovery Centre, the clients, or we call them guests, are there for 2 to 4 weeks. So we want to make them be able to achieve those goals in that time frame as well, which relates to the SMART goals. Lisa, what else do you think could help Jake feel empowered in his recovery journey?
See, I'm not very educated in some of this stuff, but I would have thought when he's ready to join kind of physical activity groups, maybe a positive
Yeah.
way, or something that gets
Yeah.
him outdoors with other people who've struggled with trauma. But it's probably not the start step. I think it would be down the process, but something that he can feel in a safe space, but also adding to that healthy, I don't know, healthy mind with activity, with
Yeah.
exercise.
Yeah. 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 So you've all done really well today. We have about 2.5 minutes left. Does anyone have any questions?
Do you work with people, obviously with trauma, I guess?
Yeah. So I work with people a lot in trauma. I work on a domestic violence hotline, which is full of trauma, but also mental health has a lot of trauma as well. Like I said at the start, I do casual days in mental health, and my at home job is on the telephone. Um, yeah, so yeah, I have a lot of experience in this industry, and I'm happy to. One of the reasons I want to be a trainer is because I want to share all the stuff I know about 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 my industry.
So you're gonna like teaching in Cert 4 in mental health?
I hope so. Yeah, yeah,
That's
yeah.
great.
Um,
Jackie,
yeah.
what do you find as, like, I guess, the overlap between kind of neurodivergence and trauma? Like
There's
uh,
a big overlap, I
is that,
reckon.
yeah.
Yeah, 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 definitely. Yeah. Okay. So just before we finish up, I just want to thank everyone for coming today. You've all participated really well. Um, you've all you've all contributed to the discussion around our pretend client. As you progress through the course, you'll get more and more confident. We've got about 12 months together in this course, and we've just started. You're welcome to email me if you have any questions, or yeah, and hopefully we stick at it and get through the course together.
Perfect. Thanks, Jackie.
No worries.
Jackie.
So we've got 20 seconds, 40 seconds left. Yeah,
Keep talking.
yeah, okay. Yeah, I can talk all day about this stuff. But yeah, look, thanks so much for coming, guys. Um, yeah, thank you. No more questions?
No,
No.
you
Okay,
covered it really
cool.
well.
Thanks. Hang on, I've just got to figure out how to stop recording.